Good afternoon, one and all. So my topic is heart failure with reduced ejection fraction in CKD stage 1 to 3. So first is why this topic? Assume a 60-year-old male, diabetic hypertensive patient with a creatinine of 1.9 with an EF of 35% coming into IOP. Very common scenario, right? So the question is, do we treat aggressively or we go cautiously? Data shows that these kind of patients, this subset is undertreated. Why? Because of the complexity of the treatment. We should know that 40 to 50% of heart failure with reduced ejection fraction have CKD. They have higher morbidity and mortality, and for the same reason, the treatment should be aggressive, but with caution. Serum creatinine of 1.9 accounts for eGFR of around 30, which is CKD stage 3. Coming to the pathophysiology of CKD and heart failure, we know cardiorenal syndrome is a vicious cycle where heart failure worsens CKD and CKD contributes to heart failure. The focus here is on CKD stage 1 to 3, where the patient is asymptomatic, but with clinical consequences where disease progression is more high risk for cardiovascular death and drug side effects. Just focusing on the 4 pillars and their role in CKD stages 1 to 3. First is ARNI, ACE inhibitor, and ARB. All these are beneficial. But when we compare ARNI versus AC inhibitors, we see that ARNI is much more beneficial in CKD stage 1 to 3, where the nephrotoxic effects as well as the hyperkalemic effects are much less, significantly low. But there should be caution when eGFR is less than 30 and potassium is more than 5.5. Coming to MRIs, spironolactone and eplerenone 25 milligram OD, benefit is definite, but caution when potassium is more than 5.5 or eGFR less than 30. Beta blockers beneficial and no dose adjustments. When it comes to SGLT2 inhibitors, there is a dual benefit for heart failure as well as CKD. The doses are dapagliflozin 10 milligram and EMPA 10 milligram, which is a standard dose for heart failure. And eGFR for consideration should be 20 and 30, 20 for empagliflozin and 30 for DAPA. Let's take some case scenarios. Consider a 70-year-old male, hypertensive with a LVEF of 35%, with a stable creatinine of 1.9, that is eGFR of 35, potassium of 4.9. The standard prescription for this patient should be an ARNI, 50 milligram to start with, titrate according to the BP, beta blockers, SGLT2 inhibitors, DAPA 10 mg, then the spironolactone 25 milligram, and diuretics as required. That's a standard patient. Second case is a 50-year-old female, diabetic, EF 35%, stable creatinine 1.9, eGFR is 28, and potassium slightly higher, 5.1. So this patient should have a prescription of beta blockers for sure. When it comes to SGLT2 inhibitors, this is where empagliflozin heads over DAPA. The eGFR is between 20 to 30, so go for empagliflozin 10 milligram. And if you need additional sugar control, it can be stepped up to 25. Since the potassium is high, eGFR is low, no MRIs. And coming to the ARNI, here eGFR is low, potassium is high, still we can continue ARNI at a lower dose with strict monitoring of creatinine and potassium. And we need to continue diuretics as required. And the last and final case, a 60-year-old male with acute decompensated heart failure with a creatinine of 1.9, eGFR of 36, and potassium of 5.5. Here initial treatment should be for the decompensation, IV diuretics. Since the potassium is high, more than 5.5, and acute decompensation, definitely you stop ARNI, MRIs. About the beta blockers, we can continue this at a lower dose because sudden stoppage can lead to higher risk for sudden cardiac death. SGLT2 inhibitors should be continued. And to conclude, treat the heart and protect the kidneys. CKD stage 1 to 3 is not a contraindication, but it's definitely a flag to monitor. Let's optimize, not undertreat. Finally, the take-home message is guideline-directed therapy works if guided carefully. Thank you.